What should you do if your doctor recommends a statin medicine? Hi, I'm Dr. Westman and welcome to my channel where I review and debunk nutritional misinformation online. In this video, I'm going to react to Dr. Suneel Dhand about his view on cholesterol treatment. And if you've watched my channel a while, I've reviewed several of Dr. Dhand's videos before. I think they're really good. But wait till the end and you'll see my final thoughts.
I want to go over in this video a hypothetical conversation about what somebody would do if a statin was recommended to them, if they didn't want a statin. Now, conversations like this happen every single day across the United States, many other Western countries, especially where the statin industry is very, very strong. And the medical paradigm is that the LDL, the so-called bad cholesterol, must be reduced at any cost.
Okay, hang on. So yeah, if you've been asked to go on, told you need to go on a statin by a doctor, you want to ask a few things. We'll go through some of these things. And Dr. Dhand has an interesting approach of being even out of the cholesterol hypothesis, he's saying. Let me explain what that means. It's actually the theory, it's not really well proven, I have to admit, that the theory that LDL cholesterol is what drives atherosclerosis and heart disease and stroke, like the major or the only thing that can influence it, which is not true. There are other things that can influence it. But how do you respond when a doctor only focuses on the elevated cholesterol and the LDL treatment? This is going to be a good interview and a good discussion of the things to think about. Hey everyone, I've got something exciting to share. If you love the content on this channel, our YouTube membership is the perfect way to take your experience to the next level. As a member, you'll get early access to new videos, be the first to see fresh tips and insights. Plus, twice a month, I'll be hosting exclusive live Q&A sessions where you can ask me your keto questions and get personalized advice. You'll also get shout-outs for recommending videos to the community, just our way of saying thanks for helping spread the word. So, if you want early content, direct access to me, and a more personalized experience, hit that join button below and become a member today. Looking forward to seeing you in our live sessions.
So let's just say that we have a 60-year-old gentleman with no significant other risk factors, and he has a lipid panel done by his doctor. Maybe the lipid panel has been monitored for a few years, and the doctor has said, well, your cholesterol is creeping up. So let's just say the LDL cholesterol, the bad cholesterol, is somewhere between 140 to 170, where a lot of these conversations tend to happen, especially in anyone over the age of 55. Doctors tend to get nervous with increasing LDL numbers, although technically statins are not supposed to be started until the LDL is higher. If people have no other risk factors, you will find many people with lower LDL numbers being prescribed statins.
So that's going to be the first branch point for me, is have you had a history of a heart attack or a stroke? If so, then we're going to have a different discussion. But let's say you don't have a history of heart attack or stroke, or your coronary artery calcium score is under 400. That puts you in a category of what's called primary prevention, meaning you're using a medication or lifestyle treatment or smoking cessation as a remedy or preventive tool to prevent the onset of atherosclerosis. So the idea that there's primary prevention and secondary prevention is really key to this discussion. So the first thing I want you to think about your own, or if you're one of my patients, come on in, we'll talk about this. Are you in the primary prevention category or a secondary prevention category? And then you'll now understand a lot of the nuance about using these medications, because even in the medical mainstream, in the world that I'm in, kind of the reviewers, the policymakers, it's not so clear that primary prevention treatment with a medication is worth it. And this idea of shared decision making is really important because you can actually make the decision with the right information.
So these are three questions if I was in this circumstance that I would have. Number one, what are my other risk factors for heart disease? Because presumably that's why you want to prescribe it, to lower the risk of heart disease, lower the risk of stroke. what are my other risk factors? So specifically, if we think of other blood tests, what is my HbA1c? That's a marker for pre-diabetes or type 2 diabetes. If that is elevated, then it's more likely that, yes, the elevated cholesterol is associated with some heart disease plaque. The other test, which I've also talked about many times before, and I actually prefer as a marker of insulin resistance, is HOMA-IR. This is where a fasting insulin is drawn at the same time as a fasting glucose level, and that will tell you often years before somebody is officially pre-diabetic whether they are insulin resistant. So if the HOMA-IR blood test is elevated, and I put a link to a video that I made not so long ago talking about this if you're not familiar with this test, if it's elevated, then that would indicate that, yes, heart disease risk is elevated beyond what it would otherwise be. What other risk factors are there for heart disease or stroke? Does the person have vascular disease? In this situation, let's just say no, they don't. And let's just say that their HOMA-IR is very close to 1 and they are not pre-diabetic. Then that would make me think anyway, as a doctor, that somebody had a low risk of developing cardiac events or a lower risk.
Yeah, so I would add in there the smoking cessation being still really important to reduce your heart attack and stroke risk. Also the blood pressure monitoring, and blood sugar is actually wrapped up into that HbA1c he mentioned, hemoglobin A1c as I call it. So yeah, and then overweight or obesity, really abdominal circumference increase is the target as well. So in the blood, it would be the HDL and triglyceride, called metabolic syndrome. Otherwise, your other risk factors were smoking, blood pressure. Of course, you can't do much about your family history, but that's really important in terms of management of these things. So these are all targeted things to reduce your risk of having heart disease or a stroke, the atherosclerosis. And remember, cholesterol is not a disease. It's really just a marker or risk factor for the disease called atherosclerosis.
So number 2, the second question, if I was not keen on being prescribed a statin, I would say, okay, so you're going to prescribe the statin because you're worried about high cholesterol in my blood test, meaning that cholesterol has also accumulated in my heart blood vessels, in my coronary arteries. So would you please order a cardiac CT scan to look at my coronary arteries and tell whether or not calcium is deposited in the coronary arteries? And I believe this is an underutilized test, and a score will be generated from the CT scan, anything ranging from 0 to a number in the hundreds. And obviously the higher it is, the more worrisome calcium deposition is in those coronary arteries. So if somebody had significant coronary artery disease by their CT scan, well, if it's very significant, then other tests like a stress test or an angiogram may be indicated to look further, but that would be an indication that, yes, coronary risk is elevated, and maybe if you want to go all out, there would be more indication for prescribing a statin medication, assuming that nothing can be done naturally to reverse the coronary plaque.
Yeah, so introducing some sort of anatomic measure, meaning you're measuring the arteries themselves. It makes sense, much like if you're going to be buying a house with a mortgage, the mortgage company makes you get an inspection of the house, the pipes, the electricity, all that sort of thing. And so in my lifetime, we didn't have these kinds of tools to look at the anatomy of the arteries until recently. So the advent of ultrasound allows an examination of the arteries that are large enough to be seen by ultrasound. And then the CAT scan, rapid CAT scan, allows you to see if there's buildup of calcium, which is a sign of healing of a lesion or plaque in the coronary arteries. So the idea of seeing if you have any damage before you use a medication makes sense to me. I mean, especially if you've lived most of your life and you have no evidence of atherosclerosis, it doesn't make sense to me to introduce suddenly a medicine to treat something you don't have. And yet it's disruptive because there aren't a lot of guidelines and long-term clinical trials to guide us, but there is enough. And the reason I got into this is because people started coming to me with elevated LDL cholesterols, eating a low-carb diet, and yet they had no evidence. In fact, they showed proof they did not have any evidence of atherosclerosis. The CAT scan CT of the rapid CT of the heart, called the coronary artery calcium score, the CAT scan was negative. The arteries in the neck and the aorta and the belly were normal, showing no signs of plaque, and the doctor still wanted to put them on a medication for a disease that they didn't have. And they were already in their 60s, 70s, 80-year-old, where they really didn't have, in my mind, didn't have the genetics to develop that atherosclerosis disease. So I found myself defending my patients' decisions not to use medication to lower cholesterol to prevent a disease that they proved that they didn't have. Now, let me say that again. The doctor was assuming that because the cholesterol was elevated, that that person had atherosclerosis and was going to develop it, but the patient went out and got their own information, and that's one of the things with the coronary scores. You may have to pay for it yourself. It might not be covered by the current insurance payment system. So this person went out and got evidence that they did not have atherosclerosis, and yet the doctor wanted to prescribe a medicine for a disease they didn't have. This makes no sense, does it? And yet that is the situation that I find myself in, having to defend my patients against using a drug. Now, why a doctor would be so pushy about a drug, it's all they have. So doctors don't value lifestyle change or exercise, diet change as a medical treatment. Most doctors just think of a drug, a pharmaceutical remedy, as the only way to go. So because that's their only treatment that they have, they may push that very hard, even when it's really not necessary. Guidelines are there if you're in a primary prevention situation, you've never had a heart attack or a stroke, and now you present evidence you don't have atherosclerosis. You don't need to be on a medicine to lower cholesterol when you have evidence that you don't even have the disease. That's primary prevention.
I would ask the question, well, doctor, statins, I've kind of been reading about them and I'm concerned about side effects. I want you to tell me, in my specific demographic, what is the true benefit of being prescribed a statin? Because actually in most demographics, the results of studies, when you actually follow the science, are nowhere near as good as you might expect. It takes hundreds of people to be treated to prevent one heart attack or one stroke. These are all true numbers. You can go and do the research yourself. So they're not exactly a miracle drug by any stretch of the imagination. But I can almost guarantee you that your doctor will not have a clue how to answer this question. Because unfortunately, the current medical paradigm, I'm not saying doctors are bad people, I'm saying the current paradigm is broken, and collectively the minds of the medical profession are broken, where they get very excited about fixing a number. Yes, of course, if you prescribe a statin medication, it will do what it's designed to do. It will lower the LDL cholesterol. But the next most important question is, well, why just get excited about fixing a number? What does that actually mean? And what does the research suggest if my number is lowered? What will my life expectancy be improved by? What will my risk of stroke be reduced by? What will my risk of heart attack be reduced by? Surely that is following the science as opposed to jumping on a bandwagon and getting all excited about fixing a number. So those are the three questions that I would definitely ask before deciding to start a statin medication. I'm not saying they're never indicated in some circumstances, like if somebody's just had a heart attack or a stroke and is very concerned and wants to go all in on doing anything possible by any means necessary to reduce risk, then a statin medication may be more indicated, but it's always an individual discussion.
Yeah, and there are some tools online that you can go to help you individualize, personalize that decision on your part. The statin decision aid tool that the Mayo Clinic has at their website, I just type in at Google or Bing, Mayo Clinic statin decision aid tool. And then this screen will come up. It will ask you to put in information from your blood tests, from your age, whether you have treated high blood pressure, that sort of thing. And then it will give you a graphic that shows you your risk. And what's fascinating is that the relative risk and the actual risk reductions have been contorted and used in many different ways to often show that a medicine or a treatment does more than it makes it seem like it does more than it really does. until you see, 100 people, 100 representations of people, and then your risk as 5 out of 100, 5%, 5 out of 100, and then you see it go down to 4% out of 100 using a treatment like cholesterol-lowering medicine. You step back and you say, even though there was a 25% risk reduction, it's only an absolute risk reduction of 5% to 4%, and my chances of having the problem was 95% no, and now it's 96% no. In your mind, that might not be worth taking on the risk and cost of any given treatment. So those tools are out there, and of course the tool says use this with your doctor to make the decision. And the data from the estimates from these tools, of course, are based on information of people who eat carbohydrates and live in the Western world. And so if you've made a change to not replicate the American diet and lifestyle, then maybe you can even do better than these calculators show. But that is something I do in my office. It takes time, and most doctors may not have time to do it, but check out these tools to help you personalize and look at your own risk. In my discussions, like Dr. Dhand, there are times when I recommend people do take statin medicines to lower cholesterol if their situation is in that secondary prevention category, where they've already had heart disease showing a heart attack or a stroke. And then the gray area is if you haven't had a heart attack or a stroke, but you have coronary calcium deposition. Nobody really knows the point at which you should start taking the medication. And you can follow people's guidelines. One of them is if it's over 400, you're kind of in that secondary prevention risk category. But still, the personalization, you might not decide to take a medicine when you're even in that secondary risk category, if you have a side effect, for example, or you're worried about some other consequence that a family member had from that medication. So that personalization of the use of these cholesterol-lowering medicines, I think it can be really important and often overlooked, as there's kind of a one-size-fits-all, your cholesterol's up, go on this pill kind of approach today.
Number one, I want you to tell me, doctor, this is the hypothetical situation of a 60-something-year-old who is told that they have high LDL cholesterol. What are my other true risk factors for heart disease? Number two, can we do a cardiac CT scan to assess my heart arteries? Number three, I want you to truly tell me, doctor, in my particular demographic, according to the studies, because of course you are supposed to be a follow the science person, what will the true benefits be? How much will this statin medication benefit me? And I may throw in another question at the end about what natural ways I can go about reversing cholesterol. A lot of doctors should be talking more about that as well, because there's always ways, assuming that the elevated LDL bad cholesterol is a reflection of insulin resistance, oxidative stress, inflammation. There's always other ways to do this. In some circumstances, if people have certain diets which are high in saturated fat, then the LDL cholesterol can be elevated. And that doesn't necessarily mean that there's any increased risk of heart disease, that cholesterol is not necessarily always depositing in the heart arteries. So the bottom line is here, have good discussions with your doctor before starting statins or any medication, and make sure that the medication is right for you.
Yeah, well, a few thoughts there. As an internal medicine specialist, I remember people being hospitalized. I've never had to do it in my own practice. Hospitalized for very high triglyceride levels. The triglyceride level can be 5,000, 10,000, 15,000, even though the normal is 150 or 100 or below. And that elevated triglyceride is a risk for pancreatitis. And so we would hospitalize people if they had super high triglycerides because we didn't want them to get pancreatitis. There's no LDL level at which someone needs to be hospitalized. And I would like someone to find that if you can. In my experience, and I'm trained as an internal medicine specialist, I could have been an endocrinologist, I could have been a rheumatologist, I could have been a pulmonary doctor, but there never is a time when the LDL is so high, you would hospitalize them for fear of, I don't know, pancreatitis, stroke, heart attack. So the idea that a doctor gets agitated over an LDL number is that they're trying to get you on a medicine that reduces your long-term risk. It's not like you're on the edge of a cliff and you have to act today. although my patients tell me that often doctors are behaving that way. Take a deep breath, consider your overall risk factor. And the other thing that came to my mind is that if you're still having to, in yourself or a loved one, manage and deal with type 2 diabetes, the primary focus should be on reversing type 2 diabetes, not reducing the cholesterol with the type 2 diabetes. So put all of your effort into reversing type 2 diabetes and just kind of ignore or put on the table aside this whole cholesterol worry, because the risk of type 2 diabetes for heart attack and stroke is 10 times higher than the risk for an elevated LDL. So I'm finding a lot of doctors are missing the right focus, the right emphasis, or the triaging of all the problems. So you want to reverse and prevent the type 2 diabetes really at all costs.
I have my own concerns. I personally will not take a statin medication. I don't believe the true benefits are anywhere near as much as the mainstream media and the medical establishment make people think. And that is from me actually looking at data and understanding that elevated LDL, much like elevated glucose, is usually most of the time a sign of something else being wrong at the body. And I, as a doctor, want to address the root cause, and I want to fix things as naturally as possible. Maybe a lot of people don't want to do that. They want to take a pill thinking that fixing the number is a good thing. But I'm sure a lot of you watching as well are very thoughtful people, and you want to also go down the natural route. So I hope this video is helpful. If you or anyone you know is in this situation, feel free to share this video with them. Let them have these discussions with their doctor and make sure that any medication, especially a statin medication, is right for them.
Well, so I was corrected on a prior video. Dr. Dhand is in the US, in the Boston area, I believe, and I like his approach, the thoughtfulness about it. Just adding on to this video, reverse the type 2 diabetes at all costs before worrying about the cholesterol level. And of course, you could do subfractions of the cholesterol level if you really wanted to look at the large and the small. But like Dr. Dhand, I'm going more toward recommending now, if you can, checking the arteries themselves to see if you have any issue. Why talk about the pie in the sky? You might or you might not. You can actually get tests to examine your own arteries, although sometimes it costs money to do that. And I've had people decline because they didn't have the $100, $200, $300 to get that kind of testing, which is, I think, unfortunate. We would do probably better to prevent by measuring and seeing if someone has the problem and focusing on people who have the problem than just treating everyone as if they had the problem or were at risk for it. But that's like assuming that because the house is on a good, nice street, that the house doesn't need to be inspected. I think we do have the resources to find out if you have the problem, and then the payment of it is something that would need to be worked out in studies showing that if you didn't treat people, didn't get these side effects, it would be a win for the payment issue. But you can make your own decision without worrying about the downstream payments like policy makers do. So, it is, to me, kind of easy if you don't have a history of heart disease or stroke, it's not in your family history, and you show evidence that you have no atherosclerosis, there's no need to take a medicine to prevent the disease that you don't have. If you already have the disease, there's evidence that there will be progression, and taking the medication can slow that down when you're a CARB eater. And just protecting my tribe here, there really are no studies saying adding a statin medicine into a low-carb context or keto context will be helpful. So it may even be harmful. That's just being a purist scientist here. In the clinic, I'll usually take the other information from carb eaters and apply them to those who don't eat carbs and have that honest discussion that we really don't know. But then you can make a decision and change your mind as time goes on, as new information comes in. So very interesting discussion. I find I'm talking about cardiometabolic prevention a lot these days in my clinic, trying to personalize how we can best prevent you from having those problems in the future. If you like this video, please like and subscribe and look for new content on Wednesdays and Fridays. If you enjoyed this video, consider joining our YouTube membership for early access and exclusive live Q&As with me. Just click the join button below or support us with a PayPal in the description.